right, I have 10 o'clock. We'll go ahead and call the meeting to order. We'll start by saying the Pledge of Allegiance, if you'll join us. Okay, before we move forward, I'd like to just read this. Please turn your cell phones to the vibrate and silence or off setting. The Opioid Abatement Funding Advisory Board allows any person to speak regarding an item on the agenda. The speaker is limited to 2 minutes unless otherwise determined by the chairperson to allow sufficient time for all speakers. Speakers shall refrain from abusive, profane remarks, disruptive outward protest, and other conduct which interferes with the orderly conduct of the meeting. Upon completion of the public comment period, discussion is limited to board members and questions raised by the board. Was the meeting properly advertised?
Madam Chair, the meeting was advertised in the Pensacola News-Journal on October 30th in the board's weekly meeting schedule.
Great, thank you. Do we have any speakers?
No, ma'am.
Okay. Has everyone had a time to review the minutes from the last meeting? Do I have a motion to accept the minutes?
Motion to accept.
Second?
Second.
All in favor?
Aye.
All right. So the budget or the opioid funding board terms, do we need to vote on that or do anything with that specifically?
We will. So for the, and we put this in here because obviously Philip and I are new as well, so we just wanted to refresh everybody on this. So for the opioid abatement funding advisory terms, so all members can serve 2 years and you can be reappointed for additional 2-year term. So I'm not sure, what year were you initiated in 2022, or do you need us to go back and look?
The third year.
Third year. So it looks like, so Kathy, it looks like your term expires in May of 2026. Same with Tommy White. John Mathis in September of 2026. Dr. Irvin, September 2026. And then Matt in May of 2026.
Okay. So that's just for information for us at this point?
Yep, that's just
All right.
information. But the second bullet point there is it does state that the chairperson and the vice chairperson have to be elected in October, which we happen to be here. So it is time to re-elect a chair and a vice chair. It does state in there specifically there is no max amount of time that somebody can serve as a chair or vice chair. So I'll just leave you with that.
Is there any way we could put this off to the next meeting when we have all of the board
We can.
members? I feel like that would be the
Yep.
best thing to do at
Okay.
this point. And next, the budget review.
All right, so to date, for the opioid abatement funds, we have received $5,498,458.51. And that includes the last McKinsey payment we received in September of $128,794.63.
Repeat that for me, please.
Sure, $5,498,458.51. Now, of that, you guys have already obligated $3,647,362.36. So for this current notice of funding availability fiscal year, we actually have a budget of $1,851,096.15. So that's the only funding that we currently have available for the applicants that submitted for this next year.
Does anybody have any questions? No, okay. So the next item on the agenda, we have the new request for fiscal year 24-25
Yes,
funding
and-
availability awardees.
And this is from Community Health. You should have a handout that looks kind of like this. The last page really breaks out the change. The big thing to note is that the total funding amount is not changing. They're just reallocating where their funding is going. Walter, do you want to come up and touch base a little bit about why you're requesting the changes?
Sure. Thank you, Board. So there's kind of a couple areas that we're trying to reallocate. One is specifically the provider. So we've brought on new MD. We entered in contracting to expand the core network into Santa Rosa County. And so in an effort of not to supplant funds or have overlapping funds, we wanted to pivot some of that funding that was earmarked for an MD to a PA that's on staff. We would like to see if we can backdate that to the beginning of the grant term, just so we can back into that full funding amount. The other good thing is that Northwest Florida Health Network has brought in some additional funding for coverage of medication. And so, again, not to try to supplant funds, drawing down that budget a little bit from what we originally budgeted for, and moving those funds elsewhere. So those are the two big areas. And then, of course, we had in our initial proposal, we had multiple 50% FTEs, and we just want to combine those all into 100% FTE. So instead of two people spending half of their time doing the work, it's one person spending all of their time doing the work within CORE. So it doesn't take away from services that are rendered. It just cleans things up for accounting and reporting purposes.
Does anyone have any questions?
Yes. So why not take those funds to bring on additional personnel for treatment? Because this is what we're trying to do. So you're going to put the workload on one person, which I think that could kind of be stressful. So you're going from a psychiatry MD to a PA, but you're paying more for the PA. And you're increasing the fringe benefits to $90,000 versus the $65,000. So you're getting, so you're paying more for a non-doctor, and you're going to increase the fringe benefit. So now, what is included in your fringe benefits?
So there's two parts. I want to answer both. So we're not paying. So MDs. So the initial proposal, the $100,000 with no fringe, was for a contract MD that was going to be quarter time. And so with the PA, you're getting 100% within the core program. We've got that MD on staff, able to do the consulting. They're just covered in other grant projects, funding that came on after this. The fringe specifically is, I think we've got it at 28.65, so that's your FICO, or FICA. That's 18% for insurance, 3% for retirement, and I believe 3% for workman's comp. And so that covers that fringe benefit. Again, in the initial proposal, we had planned on just bringing on a 1099 consult MD. That's why there was no fringe that was included in that $100,000. So for a full-time MD with benefits and everything, that runs about $400,000 a year to hire on a full-time licensed MD in the specialty.
Okay.
Any other questions?
Thank you.
We need to make a motion
Yeah.
if we're going to accept those. Do I have a motion
Make a motion, we accept the change request.
and second?
guess since I'm the only one left here, we'll second. That's just the money.
All,
Since the monies don't change, it's like, I'm just, it's one person. And I just question if there could be some additional, personnel brought on for treatment purposes, but, okay.
so are you making your second?
If I may, I just want to go over all the providers that we have that are providing core care. So we have MD that covers Santa Rosa and Escambia County. We have a total of 2 mid-level nurse practitioners in Santa Rosa County. And then we have 3 mid-levels in Escambia County. So we've got our core provider, so prescribing provider team is a total of 6 providers across Escambia and Santa Rosa. And a lot of this was due in part, we did not expect Santa Rosa Core to come on. In the way that we've got Escambia and Santa Rosa set up as a continuum. And so specifically the MD covers both counties. And Escambia County has still got more providers and a larger empanelment than Santa Rosa County. So the capacity within the empanelment for both Escambia and Santa Rosa is actually larger than it's ever been. And so I just want to be clear on that, because I understand your concern, Mr. White.
Okay. I second.
All in favor?
Aye.
Okay. The new request passed. So the next item we have is the 25-26 funding availability application review.
Before we jump into that, can I have Waterfront come up and just give you a quick update on their plan and their ribbon cutting and all of that good stuff that's about to
Sure,
happen?
Sure.
Hi, I'm Lexi Osborne, PR and Development Associate at Waterfront Rescue Mission. So we have 2 main updates. The first one is that we have submitted our first reimbursement request. It was about $301,000. That is covering basically just the purchase of the home and then the other closing costs. We do have about $38,000 that we're still going to request reimbursement for. That's going to cover the deck repairs that we did, the security, AC replacement, and just other things like that. We still have some furniture to purchase. But the more exciting update is that tomorrow we're having our ribbon cutting. It'll be at 11 a.m. and you guys are all invited. So you guys can see the 2 houses that we were able to purchase with the opioid abatement funds. So we would love for you guys to make it if you're able to. And I think that's just about it. Do you guys have any questions for me? Oh, the address. That's an excellent question. Probably have that somewhere in here. Okay, so that is going to be 5960 Louisville Avenue, Pensacola, Florida. And we do expect for the house to be move-in ready by next week. So it won't be perfectly move-in ready by the ribbon cutting. We still have a couple things to do, and we're waiting on beds to come in. But everything will be finalized next week, and we should be moving the men in within the next month or 2. So 8. It'll be 8 men.
That's great. I'm looking forward to that. Did you have something you wanted to say? Thank you so much for sharing the good information. That's
All
great.
right. Thank you, guys.
All right, so next we'll go ahead for the funding availability application review.
Okay, so we received 10 applications for this year. The total funding request that we received, and this is not including the one for-profit applicant that was knocked out just because they were for-profit and not a nonprofit, but just in the nonprofit applications, we received a funding request of $2,417,521. And just to remind you that the only budget we have remaining is the 1.8. So I sent you the link to the recording of the committee actually meeting. It was over a 2-hour meeting. We really tried to be as fair and consistent as we could, and to make sure the funding was being allocated the way that it should, to give us, obviously the outcome that we're shooting for. So with the committee's recommendation, that's just over 1.7 million. So we're just under that 1.8 million mark. And then I did share a spreadsheet with you guys that outlined what the nonprofit's ask was and what we actually recommended, so that you could kind of see where we took from. But we're open to any questions, suggestions that you guys have. I'm pretty sure most of the applicants probably are here, if you want to see if any of them want to come up and talk about what they're trying to do.
I'm open for them to come up and just
Okay.
give us a overview. That would be great.
Okay, we'll just go in order. Is anybody here from Brightbridge?
Hi, my name's Cheryl Hennon. I'm the Assistant Director at Brightbridge Ministries. Honored to be here today. Just a quick overview. Is that we are currently under renovations, which will add about 40 beds to our existing shelter beds. We currently have approximately 50 beds, so this will almost double our capacity for housing. With this additional funding, we are going to be working with core providers to now, for the first time, be able to designate some beds for opioid use disorder. We will be working with MAT treatment with our residents, which we have not been in the past. This grant, I will say, I can go through, but I know you all have this exact amounts. We'll provide funding for case management, additional funding for our shelter, specifically shelter manager, a new assistant shelter manager position. These are all, it's a percentage as we're adding beds. Occupancy cost, also a percentage. Mileage reimbursement, life skills classes, also food and a kitchen, percentage of that position, computer and copier, and then opioid-specific abatement training, background checks, and a small portion for administration cost.
Okay, so this funding would in essence double the beds, you said, for?
So it will help with
Help towards that.
Help towards,
Okay, gotcha.
yes,
Just
yes,
wanted to
not for
clarify
any
that.
of the renovations or anything. This is really looking ahead at helping us fund what will be needed, a percentage, a small percentage of that, yes.
Great.
Thank you.
Do you have any questions? Anyone else? Philip. Liz, do you have an extra pen? This is the ask, this is the suggested amount. So the ask was $242,011, and the ask, or the suggested amount from the committee was $167,958.40. Thank you.
Thank you so much.
I'm going to move to the next. EMS Core, just for a brief overview.
Good morning. So we are currently asking for mobile clinics. In particular, we were asking for two, a total of $541,066 to be down to the penny. What has happened is wonderful things. We've boomed. By boom, I mean we've boomed. 299 patients through the end of last month. Total 490 just when we celebrate our 400 milestone. Boom. So that, and looking at the homeless population, lack of safe space for our providers to dose safely, really spawned this, not to mention with privacy concerns as well. And in truth, there is only one truly dedicated core asset, which is a 2021 Ford Expedition. We are borrowing one from EMS, which is a 2017, nearly 75,000 miles. So this is what has spurned our the need to make sure that we can push forward.
Are there any questions? Thank you.
Thank you.
Next, I have Health and Hope.
Good morning. It's Larry Brooks with Health and Hope. I'm their CIO or CTO, and standing in for our ED. Our project is to scale our existing infrastructure. The Narcan Distribution Network, Mobile Outreach, and newly launched Health and Wellness Center. We provide Narcan to other organizations in the community, in addition to opening up our facilities, in addition to the newly built Health and Wellness Center that we just opened to the community as well. So we're providing education. We also have mobile outreach that we're doing, and we're also providing language translation services and education to support the additional communities that we're out there to support as well.
Yes, I have a question.
Yes, sir.
What is their ask?
$260,000. The suggested amount's $227,500.
Okay, so exactly what do you do as far as okay, our mission is for opioid abatement. And so like currently, what do you do that deals with that?
We provide education. We provide Narcan distribution.
Do you do any treatment?
No, we do not do any treatment.
Okay, so how would you enhance our mission? Because I hear about the health center and all that stuff, but we're not really tasked for a health center. We're tasked for opioid abatement that that falls under like treatment and things of that nature. The Narcan distribution, that kind of falls into that. But at our core, we're there to kind of help to get people dealing with the opioid epidemic situation. Not really kind of, to facilitate health centers for the community. And there's a space for that, but that's just not our mission. So what will you do? So when you're asked, how does it directly help us to solve our issue?
So the population that we're reaching out to are typically underserved, uninsured, and we have.
So again, like CORE deals directly with people that either have overdosed or got. That's their core mission. That's when they get that call. That means somebody is dealing with that issue. Again, how does your mission help us solve our issue directly? How would you do that? Out of everything you do, it doesn't have to be everything, but give me something directly you do that goes directly to the core of what we do.
We're part of the preventative side of that.
Okay. And so how do you identify your individuals and what you're looking to that you deal with that helps us with our issue?
One good example is that rather than some of the, say for instance in our dental suite, we have people that seek street drugs in order to alleviate pain. And with the pharmacy that we have in-house, we're able to direct them away from those and provide drugs that are provide legal drugs so that they can have that pain abatement, in addition to providing them with the dental services to assist with that process.
So if someone comes into Hope and Health and they're coming in there for dental, but then you identify a issue with opioids or drugs, whatnot, then what happens after that?
I'm not able to afford to pay for medicine, so I can come to Health and Hope to, one, get the chief complaint taken care of. I don't have to seek street drugs in order to relieve the pain that I'm feeling from from that dental issue, and I'm able to go to the pharmacy there at Health and Hope and get access to free treatment or free drugs in lieu of street drugs to relieve that pain.
Roger that. So once you identify that, then what happens to that person after that? Do you just give it to them and then they just kind of like go off willy-nilly and then they just come back afterwards and it's just a repetitive cycle? And you don't really have a system of getting them actual help. It's just kind of like give them that for the moment, and then what happens after that? Is there any?
There's a continuum. There's a continuum of care. We stay in contact. We have an in-house EMR system, EHR system. So we've got over 400 volunteer doctors that are providing their time and effort to ensure that those patients or the people that come to the clinic to seek care are able to get those. And those things that we cannot provide underneath our roof, we're able to direct them to other facilities within the community to provide the things that we ourselves can't do underneath our roof at zero cost.
Last things, and who are your partners in the community that actually does that? That if somebody has to go to, that's a serious case and actually want to get weaned off, who do you partner with, or who do you call to get them to that care?
We're partnered with Baptist, Ascension, and Lakeview Center as well. And rather than a number of those patients filling their ER, we're able to divert some of that traffic to Health and Hope Clinic to seek that care and to get that free care, and then forward them back to other services that we can't actually provide.
Roger that. Okay. Only reason I'm asking those questions because it's the first time we've ever seen y'all in the total of our existence. So, point of getting to know you. And this funding is going to be to help expand what?
The existing services that we're providing. So we've already been doing quite a bit of this work. So we're just expanding that.
Okay.
I'm a volunteer at Health and Hope. My name is Huntley Jimenez. And, according to the Department of Health and Human Services, preventing substance use disorder is a first step to addressing overdoses. When people don't have insurance, they're more likely to self-medicate, like Larry was saying. If they're in pain, we provide dental care, full medical care. We can provide prescriptions, for whatever condition, they're having issues with. Also, prevention is our main focus, but also we're the Northwest Florida's provider of Narcan, so we can provide in bulk and individual. So we are the provider to the other nonprofits.
Should have led with that, see?
And we've been doing that. We want to continue to do that, and we want to increase that service. And we do the training. We do, Narcan training, CPR training, all those things too.
Okay, it's real simple. That goes directly to the heart of our mission. That's all I was. So when you kind of threw me off when you were saying like you want to do a community gym or something, I'm like.
And we have a new health and wellness center that provides mental health counseling. And we, as a volunteer, I see on every patient visit, we do a mental health assessment for each patient. And we can identify problems early and get them the help they need early.
Okay, so you're the Northwest Florida Narcan provider?
Yes.
Okay, roger that, got that.
Yeah.
All right, thank you.
I'll work on my presentation next time.
Thank you.
Thank you.
I'm just simple and country, man. I just like, direct to the situation. So thank you, sir.
Roger that.
Do you have any other questions?
That's it.
Okay.
Thank you so much.
Thank you.
Thank you.
Hope and fear.
Hey, I'm Stephanie Shepard, the Executive Director of Hope Above Fear.
Hey, Stephanie.
How are you?
Long time no see.
I know,
You've been busy.
It's been busy, yes. So
That's good. How you doing?
I am excited to be here.
Excellent. I'm so glad to see you back, Steph.
All right, so our application primarily is covering staffing programs. Two of our programs, our Choose Your Story, which is our prevention program, and Better Without It, which is a new diversion program that we are, well, our first class actually is this week in partnership with the Escambia County Public School District. And then in addition, education, with billboards and another video that will be designed by youth for youth. And then I think some of the others was a small portion for administrative costs and licensure and training. The Better Without It program is a program that we are utilizing from South Florida, from Brevard County. And so there's a small fee in that, and then also just bringing the executive director from Brevard County Prevention Coalition back to Escambia County to do another workshop and training.
Good, good. Well, glad to see you back. You persevered from the first time you came. Most of y'all probably don't know Stephanie's story, but Stephanie came before us when we first started, and she had a super impactful story. And all Steph was looking for was help for her son when he was going through school. And she couldn't provide it here. She couldn't find it here in Escambia County. And she had to send him off and back and this and forth. And it was just, it was tragic, super tragic. And before she could find him help in lieu of, he ended up passing from opioid addiction and from overdose, which set her on fire, which set her out to start what she's doing now. In lieu of when she first came, she's been hard at it. And so proud to see you back, so proud to see that you actually have brought to fruition what you first started out to do, because that's a very hard thing to do, to go from conception to reality. And not only go from reality, but to actually put the guts and the work behind it and to actually stay at it. So proud of you, and so proud of your organization, your team. Hopefully to meet your team one day, maybe the next meeting, bring them. And so glad to see you. So glad that you haven't given up to make a difference in other kids. And you're in the public school system now, huh?
Well, that was a tough one, but we're there.
Yeah, I hear it. Escambia County. I got to have some talks with some of the people that I know that sits on that board. It's like, why is it so hard to get drug training in our school systems? That is unbelievable. That is just unconscionable, but you're there. Thank you for everything you're doing, and I know you're going to be great, so thank you.
Thank you.
Any other questions or comments? Thank you. Next, we have Lakeview Cat.
Good morning, it's Patty Hyde. I'm from Lakeview. I'm the Director of Family-Based Intervention Services. Just an update on the CAT/AIM program. We have hired a case manager, and so she begins today. We're real excited about that. Now we're fully staffed. We'll be able to expand our group. Right now, we are working mostly with the task kiddos that come from DJJ. We are opening up to the clinical part of it. The task families mainly just participate in the group process. They don't particularly want people in their home to provide therapy services. And so now we're starting to receive referrals from those who do need the therapy services. We have a therapist going into the home, doing individual therapy, doing family therapy, especially around like conflict management, which is, right, developmentally appropriate for teenagers. But when there's substances involved, whether it's from the teenager or the family themselves, we do a lot of work with conflict resolution. what else? The ask we had in our new application, the two highest needs that we thought were highest needs, one was the travel. It was pretty extensive, and I understand, you know, that you have so many people that have applied. The intent of it is that usually transportation is the number one barrier for not just adults, but for kids getting to treatment, getting to group. And so we provide our group after school hours so that they can access it. But we also try to send out a van, a Lakeview van, to different parts of the city where parents can drop their kids off. It's just maybe right down the block from them instead of 10 miles down the road. And so we try to pick them up and deliver them at before and after group. The other one is for a support staff, a part-time support staff. Last year in our application, we had requested an RN / case manager that we were never able to hire. And so we requested to shift that to a regular case manager. And then with the savings left over, hire a part-time, we call it admin assistant, but it has nothing really to do with administration so much as because we are out on the road a lot, we just need somebody to be able to answer the phone and direct referrals and keep up with that kind of stuff. And so it really came out to the same amount last year. When we requested that in June or July, we were told we couldn't hire the support staff this year because it wasn't in our application. So we put it in next year's application, but that was declined. And so I just wanted to make sure y'all understood it's in the application itself what that support staff does. And so really it was not a higher amount of money. It just went for a different person is all. Do you have any questions for me? Those were the main points, but there are others if you ask me questions.
Well, good, Patty. How you doing?
I'm good. How are you?
Good. You guys have been hard at it. Well, congratulations on your new hire.
Thank
or
you.
Not. And so with that new hire, so that's going to help you to increase your, I guess, people that you see by approximately how many?
I'm sorry, how
About
many?
how many that, with the increased staffing, that you would be able to see?
Right now, we're seeing, with the reduced staff, we were able to see 7 to 9 people. And now this will help us get up to the full. What's different about our program than a lot of others is we do community treatment. We're considered community-based. So we go to their homes, we go to the schools, and we do transport. And so that means most of our staff are out in the community, and there's nobody at a desk, let's say, or a standard phone that can people can call and ask questions. They network with our schools and say, hey, you know, if you have this population, let me send you some brochures or some flyers, and I can schedule you one of our team members to come out to your school and give a presentation.
Okay. And your age group is from what age group?
Right now, so it's a little bit different next year. Right now, we said 5 to 18, and the reason it's 5 to 18 is we hope to impact kids whose families' use of substances impact their function in school across systems. Next year, in our new application, we requested 13 to 21. 18 to 21 is really our sweet spot. That's when kids, that maybe they have been in there at 16 or 17, and then when they turn 18, we're free, we're doing it, you know.
Right.
And then, but at 19, they say, I can't keep a job. I need to come back to y'all, Miss Patty. And so some of those clients are our most successful.
Okay. Sounds good. Thank you all.
You're so welcome.
And you should get with Stephanie, man. And Stephanie, you should get with Miss Patty because you can see how you guys could be a benefit to each other as far as what you do and the age groups that you guys are trying to impact. So
We actually hook up some of our clients from our continuum of care with her group.
awesome. Thank you.
Thank you.
Yes, ma'am.
The next, we have Ministry Village.
Hey, I'm Stephanie, and I'm from Ministry Village. We're seeking funding for our Cares House, our women's recovery home. We're seeking for an in-house substance abuse counselor, also a case manager, educational materials, staff training and certifications, and then also we're seeking funding for our Project Reconnect, specifically those that are trying to travel out of town to go to recovery centers.
So the funding that you're asking for, so of that is going to be a case manager, you said?
Yes.
And what's the other person?
And then an in-house substance abuse counselor, an actual licensed substance abuse counselor.
What are their salaries?
I believe it was, our ask is like 93,000. Okay.
For both of them or one?
No, that's just for the in-house substance abuse counselor, and then for the case manager, I believe it was 50,000.
Okay. And that in-house substance abuse counselor, they're going to hold a,
They're going to meet with each lady individually once a week, and then they'll also hold group counseling sessions with them as well.
so is that a person with a master's or is that a person like with a, like what that counselor, that's almost 100,000 a year?
I'm not exactly sure, like the schooling on that. Probably.
I haven't read it.
Yeah, I'm.
Only an LMHC, which is beyond a master's degree.
Okay.
I don't know.
Okay, all right.
Sorry.
You know, because everybody's throwing around this counseling word today and, you know, in different spaces and without a whole lot of credentials behind them. So just, you know, when you get up to about that 100,000 for one person, you kind of, you know, want to make sure that they have certain kind of credentials or whatnot
Right.
behind them. All right, good.
Okay.
Thank you.
Thank you.
Is there someone here for a fenced or? Okay, that was the profit one? No, okay. Is the next one REAP? Sorry about that.
Good morning, Vinnie Wibbs, Executive Director of Reentry Alliance Pensacola. With me today is Melinda Heim. Melinda has a master's in nursing. She is my executive assistant. The nature of our program is pretty simple. We propose to have 2 houses, one for men, one for women, staffed with a case manager in each one of those, along with a peer review specialist that will be residing inside those premises. The idea is to work with individuals, for the most part, that have been referred to us from other organizations, working with this core, referrals from the various hospitals that we kind of partner with, and to work with those people on a residential basis.
And so the monies in which you're asking for, is it for just the staffing, or I see that's?
No, it covers the rental for the 2 houses, one for each of those, all right, for a year's worth of rental, and then staffing a case manager for each of the houses, and then a peer specialist for each of those houses.
And how many people in those homes will be able to? How many people will you be able to facilitate? in those?
We are projecting right now a total of 15 between those 2 houses, and then as they cycle through the program, we're expecting that probably a 3-cycle period during the course of a year.
So roughly every 4 months, there's going to be a new batch.
That's right.
Okay, so new batch, so 15 each throughout each period.
That's correct.
So you actually have a recovery program already in place?
Yes, the history for Reentry Alliance Pensacola for the last 13 years, we've been providing reentry services for men and women who have been returning from incarceration. About 3 years ago, we added working with people that were described by HUD as homeless individuals. And so we have a considerable amount of experience in this field. I can tell you basically that probably right now with the individuals that we started out in the reentry program, about 75% of those people have some kind of a history of addiction problems. Most of them also have some kind of mental health issues. And so although we aren't providing those kind of services, we work very closely with a number of local agencies, some of whom you've heard about already. And so our goal is to get these people in, get them the initial help that they need, and we will pick them. A lot of these people will be coming from like the emergency rooms and stuff like that, and need a place to go into.
So your biggest goal is to facilitate the housing part of the situation, you're not really the treatment part.
That is correct.
So once you, I'm just trying to understand the process. So once you get these people in, how do you, where's the resources come from housing them?
Okay, where do the resources come from housing? Our experience right now, REAP has, right now we have 22 houses. 20 of those are in Escambia County. There are 2 houses over in Santa Rosa County. We have a good relationship with a number of local landlords and marketing representatives. So we've had a good history of working with these people. So we feel like there's no difficulty at all in getting the houses that we need and getting the referrals. Regretfully, there's a lot of potential clients to be coming into those.
So when these people enter these houses, would they have to pay you rent for being there?
The reality is that most of these people probably will have difficulty doing that in the initial stages. We have in the past established a program whereby the first period of time that they're with our program, whether it's the reentry program and the homeless program, we don't charge them for it. Then once they get stable, then we'll figure out what they can afford, and then we'll start charging for that.
Okay, so, but we're not tasked for like reentry and homelessness. We're tasked
No.
with opioid abatement and treatment. So I'm trying to figure out
Okay.
where in that particular role will you help us meet our care versus housing and, being basically hopefully not a rental facility for people that's transitioning, like where in what you do directly help us to achieve our goals, like and track, and not only that, but also real-time tracking, like, hey, this person came in, they had this issue, this is what we did, and now this is what's going on with them. And I go back to CORE, because CORE got a hell of a tracking program that they can track from start to finish. And so now I hope that everyone here understands that, that's what needs to be done, especially when you're dealing with these funds, because we have specific guidelines that we must go by, and we need specific outcomes that must be met, and we must be able to quantify that and be able to show and prove that, because I have to go for people that appointed me to this board and give a report. And so versus money just going out. So my question to you is, how are you going to be able to not only to track, to document that, track that, and follow up with the results of that particular individual versus just a pass-through, like them just passing through your space, and then it's just kind of like, what happened? And there's nothing there to quantify that.
Okay, and I appreciate the need to try to explain to that. We see ourselves as an individual who has been treated in an emergency situation, coming out of a hospital emergency room or some other facility that needs a place. These people do not have a place to stay. They don't have any guidance. And so we step in at that point in time, and we provide them with case management and a peer support specialist that can help them. Our goal is not to keep those and provide, a forever situation. We expect that they'll be in, they'll get some immediate care and treatment, counseling, guidance, and then they'll be able to move to the next step. So it's really designed to be a transitional program, taking people that are just being released from an emergency situation or referred to us from CORE and moving forward with that.
Will you charge them rental to stay there?
At this point in time, I can tell you that in our request for funding.
In other
I think
words,
it was
we
20
can't, I don't think it'd be great for us to subsidize housing that you're going to turn around and charge a person to stay at that house that you're getting subsidized from the board, because our main thing is treatment, and that's way out of our scope.
Well, let me
Because
say.
when people say transitional housing, that's exactly what it means. Like, okay, you're gonna stay here for a period of time, but this is gonna be your rental payment while staying here.
The amount that we projected and was at least tentatively considered was like $21,000. I think it was $24,000, $25,000 rental for the two houses. And you can tell that using current market rates right now, that would not be enough to have two houses that would house like 15 people. So I would expect that there will be some charges. And I think that this is kind of go along with the concept that an individual has got to be starting to carry their own weight. It's not designed to be a free ride for anybody. And so we're going to step in and take them from that hospital room, emergency room, put them in a place, get them some guidance at that point in time, and then move forward so they can be on their own.
Okay. I can't support that. And the reason being is because I can't consciously support subsidizing a situation in which you're going to turn around and tell that person that they have to pay to stay there. That's the whole, I'm just not, I can't wrap my head around that particular thing now. I just,
Can I interrupt a minute? Mr. Wibbs, is it not true that a large percentage of the people you have coming into your reentry program are addicted to drugs?
A very high percentage have that history or are currently addicted. That's correct.
And I did not hear you say you're going to charge them rent from day one.
No, we
What I
did not
heard was-
anticipate doing that. And I think it's important, as part of the what I'm going to call the progressive situation, they may be flat on their feet, no money whatsoever. They need some help immediately. As they're coming out of that emergency room is a good example. They need some help right off the bat. As they get stable, if the program is working as it should work, they'll get to the point where they have some income, they can move forward, and that's kind of the concept of it.
But it's not reliant upon them paying income to
Absolutely not.
stay there. Okay. I might just also, Liz, y'all went through all this, right? And how many hours did you say y'all did with this?
Well, we had two meetings. The second meeting itself was over 2 hours. I think for Vinnie's program, they did ask, to your point, Mr. White, is they did ask for the house, so the rent, the utilities, the water to be covered by this grant. And again, our agreement's only a year long. So as they put people in these two houses, they should not be charged any rent. Now, when they transition out, part of the case management absolutely is to figure out, how do we get you a job? How do we get you benefits if you qualify for them? Because they're going to have to transition out and pay income and become a citizen, obviously, at some point. But in this housing, correct me if I'm wrong, Vinnie, it should be the rent, the utilities, the water will be paid by the grant for that year.
That's not what he said. He said there's some point that they're going to basically pay. He didn't say that, okay, that no one staying in these houses is not going to have to pay anything. He said that at some point there's going to be an ask. And so what does that mean? Does that mean 30 days in, there's an ask? What does that mean? And so I think it has to be I'm not against helping them, but I don't think the language is clear enough to make a decision right now. What I'd like to do is table his ask to the next meeting and get something in writing with you all, concrete with the county, that, hey, there should be no rental payments from any occupants of this dwelling while they're going through this particular, and this dwellings is for this particular program. In other words, you can't take somebody that's just want to be transitional house them, stick them in there, and then kind of like they're paying you and you're taking up bedding from a person that's really that needs to be treatment, because we need to stay zoned in on our mission, because there's people with a lot of different missions, and they're trying to wrap around their mission into our mission, and it needs to be directly stated in a contractual agreement. There would be no charges for people that are entering into it, because it is being subsidized by this monies, and I don't think that's like double dipping, and so we're not gonna, I can't support that.
Vinny,
So I-
so is your understanding for your ask, it was $25,680. Would that cover the full year of rent, utility, water?
We expect that that would be less than would be covered, but REAP would accept that responsibility for anything more than that amount.
Okay, so we can build that into our agreement, for sure.
Okay.
I also think that I'd like to request job descriptions for each of these positions, because you did bring up a good point. A case manager to somebody might not be the same as a case manager to another. So whatever you guys vote to go forward, we'll get job descriptions and what the qualifications are for those positions, so that we know that the salary is common for our area.
Right. So this is what I like to do. I like to make a motion to table the REAP ask till the next meeting, till we can kind of get some clarity with the communications on what's expected of REAP, how that is supposed to be done, and what's not supposed to be done as far as charging people to be in these houses in which they're asking for, specifically what they're to be utilized for, and that's for opioid treatment, abatement, and getting people to transition off in some kind of defined way of a program like Ministry Village. They have kind of like a defined way of transitioning out, and they have a path. And so it's just kind of obscure right now, of like, you're getting there because you came before, so we're building.
That, yes.
We just got to get some definites, because again, we're tasked with a certain objective. And I know there's a lot of different ways that you can help people. And I understand a person with substance abuse may have this issue, that issue, this issue, this issue. But however, we're here to deal with a certain issues, and that's what we must stay on task with.
I have a question.
Yes, go ahead.
Liz, this is for you. Did not all these groups that you're coming back with suggestions that y'all reviewed and you feel that it fits criteria for what this board is?
We did. We did not request specific job descriptions or anything like that. And it was specifically for folks to stay. I'm familiar with REAP. I kind of know how their process goes, so I have a little bit of an advantage. But yes, all of their applications did meet the intent of the opioid abatement funding. And we, like I said, we were very consistent. We only agreed to pay rent or utilities if there was actually people in need receiving those services. So like if somebody asked for office space rental, we did not approve any of that. It had to be, physically people who are in need staying in these locations for us to assist with something like that. I don't think it's out of the ordinary to request that if we are going to subsidize, but I think also part of the case management is making sure these folks can get jobs and they can get income, and that they, can become functioning citizens of our society. So, and we can, outline that however we can. But yes, we went through that very, very extensively.
Well, thank you.
And they specifically partner with some other agencies that provide the actual treatment for the participants or for those that stay there. So.
Yes, and they did provide letters of support. I know that they work with our core team, they work with Lakeview, they work with Opening Doors. They're very involved with all the partners.
Great, thank you. Any other questions? Thank you.
Any other questions? Okay.
No.
Okay.
Next, we have the YMCA.
Hold on just a second, if you could. Where do we stand on that issue, the REAP, at this point?
Well, I made a motion that where we get the language cleared up as far as the rental, that we table the the REAP ask until the next meeting. That was my motion. So until they get with Elizabeth and we get some clarity on the language and the, what's going to be the rules of engagement with that funding, because I'm not comfortable going into it without clear language that says, you know, a person that's coming into that staying in these dwellings cannot be charged rental agreement. Right now, that language is not there.
And just to be clear, the specific one is around the rental, right?
Yeah.
Piece of it, which is the majority of theirs, okay.
Okay, so there's a motion on the table. Do I have a second?
Not denying them, just to the next meeting until they come back, once they get together and clear the language on the direction of how it's to be utilized.
And their year will not start until the contract is executed, so if they are pushed back, they'll get more time than everybody else, just so you know.
I have a question. If the motion dies, then can we move forward on listening to the rest of them, and then at that time, push everything back if we choose to do that? Okay. I don't have a second, so I'm going to, that motion dies. YMCA, if you would come up and give us your presentation.
I'm Jennifer Barris with the YMCA of Northwest Florida. So we are seeking funding to bring a Community as Medicine group program to the area. This Community as Medicine program was developed 10 years ago by clinical psychologists from an organization called Open Source Wellness. We are looking to partner with Community Health in terms with their core program, where they would refer individuals to this program. So the Community as Medicine program is led by board-certified health and wellness coaches and consists of 4 aspects, which is physical activity, mindfulness, nutrition, and then small group coaching. So what we're looking to do is run this program 3 times throughout the next year and reach approximately 50 to 60 individuals. So again, individuals would be referred from the core program through Community Health, and it would help them to develop more autonomy, healthy habits to hopefully avoid any relapses or other health issues that may occur. So most of the funding goes towards staffing for the health coaching, so we have to get them board certified, as well as just general staffing costs to run the program. And then in addition, once they complete the program, we are offering a 12-week YMCA membership and also sessions with the YMCA navigator to help them learn how to make connections within the area, different resources that are offered, and also just utilizing the facility and making connections.
Are there any questions?
Do you guys want to hear from Walter on this as well?
Sure.
Since it's coming from his core
Yeah,
group, there is an
sure.
intent behind
Yes,
the
okay.
circle.
Yeah.
So, thank you again. So, the intent of this is so we've got, in credit to the core program, it has grown substantially. And our mechanism of care is we get you in, hopefully get you stabilized on the MAT medication, and then the ultimate goal is to start titration down. Part of that and instrumental towards titration on the medication and full integration in the community is community connection. And so this is almost the intent is a staged step down. So as we start to pivot people out from more intense care within the core treatment model, so they start with EMS, they come to us, we want to be able to refer directly in to this program. And our partnership in this, what we're going to be looking at is layering in the medical support. So some of these classes will be co-located in our clinic, in some of our sites. And so we're looking at innovative ways, not only for them to have their health coaches, but there's going to be that behavioral health aspect, medical care, to where essentially startup costs, launch, we figure out a way to work with YMCA to bill, if allowable. And then we pay for it moving forward. So it would be a service that we would provide to our patients through CORE moving forward. So this is the startup cost because it's going to take us, honestly, about a year to figure out a way that we can basically cut YMCA a check so that we have this as a support for the CORE patients. I hope I didn't make that clear as mud.
Any questions?
But I think the intent too is to transition them a little easier so that you can take on more patients.
Absolutely. So it's a step down. So again, we start really intense resources with the EMS side for those couple weeks. They come to us. Again, we leverage in those really intense resources. But we don't just want to pivot someone and say, hey, come see us, so long. This is kind of that filling in that gap to kind of step them down. And we know, well, I'll speak my personal experience. One of the biggest parts of my own recovery was finding my community, finding my connection, finding my people. And when you look at the model of community as medicine, that is the model. So it's you know, the intent is the individuals, you know, they've gotten stabilized on their meds, they're housed, they're working, but they really haven't found that third place. They haven't found that support network. And so then we would pivot them into this, and the model has demonstrated that it helps support them through that transition.
You know, I hate to be the assignment of American Idol. You all are really taking us out of our scope with some of these asks. You're I'm not gonna say you're crossing line, but we're really kind of pushing because I don't really remember seeing YMCA memberships in our CORE outline. I just don't remember seeing that part in it. I understand the idea of continuous treatment, but at some point, you know, you CORE, you do a great job, you get it there, boom, 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 you got the transitionality, they back working, they all of that. So my question is, and you're saying this is the startup. So I have a question, Walt. You know, so out of your reallocation that you came up here in the beginning, why couldn't that have been reallocated to do this program?
My understanding with the grant approval that went through the BOCC is that we could only reallocate within specific line items that were the initial grant. And so for us to try to reallocate and go into this, that's essentially a new grant narrative. I know initially when we were talking about even working with YMCA on this, we wrote the grant as us being the primary on it. And then when we really looked at it, we said, that doesn't make sense because it ends up just being a pass-through. And so, and kind of thinking that through, you know, this is the YMCA program. We come in as we've got the referral source for the patients that need the care.
Right, but I'm not understanding what is YMCA gonna, if the person has already then went from through the CORE, through the other treatments, and they're already, you know, I'm just not understanding, see, where outside of, you know, you said health and wealth, I just don't understand what does this program even does? What does it even do?
So it's a 75-minute program with 12 to 16 people in it, and they meet every week. And so like I said, it was developed by Open Source Wellness, and they go through, basically their 4 pillars are move, nourish, connect, and be. And the biggest piece of it is the community building. So they're learning from board-certified health coaches and from each other how to make healthy choices, build healthy habits, be sustainable and more autonomous in what they're doing for their overall well-being.
But don't they get that coming through all the other programming? I'm just not understanding. It's like an overlap. I mean, like like, why go all the way through the core program and isn't that part of the case management and all the other stuff preceding to coming to this program?
So,
I mean, it'll be an entire waste of monies to go through a program and a person still don't understand healthy habits at the end, and they get all the way to the end, and you tell them that they got to go to another program to understand healthy habits. What is case management?
So from a case management perspective for us, so we operate under medical case management, and the difference is you've got I don't want to say power imbalance, but you know, we're professional case managers. We're going over all of these things, and so this is almost when we say coaches, this is a peer support led continuum.
But you have peer support.
For substance use, and that's their focus on substance use. And when you, how do I say that? So we've got, 375 core patients. This is giving that more intense. So every core patient works with our peer support specialists. But again, we're putting out fires. We're just trying to keep people sober. This is kind of a handoff to the next group that can really dive in with more nuanced things. And just to be completely honest, dive in areas that our peer support specialists and our case management just can't get to. And it's not unique to us. I think that's across the board. It's been about a year since I've been in direct case management, but I managed 120 different patients as one case manager. And there was always stuff I wish I could do more. I just didn't have enough time. And to be clear too, this is startup, and this is, once it's funded and start up, it's a resource that's going to be in the community and continue to grow. So this is, again, going back to one-time startup cost, boom, it's here. Community as Medicine is a resource that will be available.
What is it called again? What's the name of it?
Community Medicine.
Yeah,
Community with Medicine. And so you said it's a startup. So how does it get funded thus going forward? I mean, everyone says that coming in.
That's where we come in with billing. So one of the things is we've talked about co-locating it at our clinic site at Palafox 2. We've got other pokers in the fire that I can't, but we've got clinical spaces there. And so it's a resource. So we bring somebody in, let's say you've got your monthly checkup. You're coming in for your monthly checkup, you're going to your Community as Medicine class, your therapist may be there as well. And so having that resource for us, we're sustaining it and we're gonna pay the cost. The idea, the business model is we pay the cost of the Community as Medicine class for our patients because we're bringing them in and able to provide medically necessary care for the continuation of their care.
Yeah, because I seen in the budget, I ran off and left my sheet, but I seen like money's in for kitchen staff and.
No.
That's not for this.
That wasn't, okay, I was looking at the wrong.
Correct.
Okay.
Okay, I think.
Yeah, go ahead.
Go ahead, John.
Okay, just a quick question. Isn't this just the continuum of care providing? Okay. I don't know. I'm not so opposed to it. I'll put it that way.
I would like to say I'm not opposed to it. When you deal with someone that's addicted, truly addicted, you can't send them through treatment. A lot of times it's not one time at treatment, and it is a continuum of care. You do want them to be connected to the community for them to be successful. I see this as a perfectly flowing right into that and making that connection. So I'm definitely not opposed to it. Like I said, I've seen it in substance use programs. They have these type of services that they provide.
And so what happens after they leave your program?
So that's part of why we added the 12 weeks of the YMCA and having a navigator to help, build connections within the YMCA. So the hope is that, they'll stay connected with the coaches that they met, with the navigator that they met, with the people in the program. So essentially it's 12 weeks in the Community as Medicine and then 12 weeks in the YMCA. So a good amount of support.
So when you're dealing with substance use and someone that's truly addicted, they have to change everything about their lives to be successful. So their whole core group of friends that they were using drugs with, they have to totally get away from that, and this helps bridge that gap so it connects them to the community.
So that's a little short of 6 months, 12 weeks. So, and how many people at one time does this service?
Our goal is to have 12 to 16 people in each group and run 3 groups in the whole year.
Okay.
So it comes out when you, and I'm an ROI number, what's the return on investment? I think the ask is around 76,000, about 12 to 1,300 a person. But again, think globally, 12 to 13 a person, one-time funding, this program stays around for years, your ROI, so, you know, your cost goes down, your ROI gets bigger.
Right, I understand, yes, because I do business on a daily basis, and that's why I have these questions around numbers and things of that nature. And so, all right, but my last concern is, you said it's going to be in the community for years, and so my question is, you're saying it's going to get funded down the road, and my question is, if that's the case, why couldn't you have funded it now?
Because it's startup costs. So we want to be able to get the billing in place. I mean, that's it. It takes us. I mean, when we look at the way that I was trained to write grants and look at program implementation in public health spaces, the biggest thing is if you can get startup costs and you have a business model for sustainment, that gives you time to get the billing in place. Because again, in
Hey,
business,
Walt, I understand. Say, look, Walt. You come up, you're like the representative for 3 situations now. You cannot suck up all the opioid budget, You got Northwest Florida, you got CORE, and now you're talking about YMCA. Walt, come on now. So I'm just saying, when you add all those up in one ask, those are pretty much, that would almost suck up the entire what we have right now when you look at those 3 combined. Not to, when you look at your initial ask for Northwest Florida, CORE with their ask, and then, you know, you look cherry on top of YMCA. It's not almost, but it's of that 1 point,
we're not asking for any money this year. Community health isn't.
The half is from the last session? Okay, all right. Well,
We intentionally, because I remember your questions last year. You said, hey, is this one time? And I said, yes, this is, and so we did not come.
Okay, all right, I've just seen you a lot this year, that's all.
I come to all your meetings.
All right, all right, thank you, ma'am. Thank you for answering that questions.
Thank you.
Thank
All right.
you. Does anyone have any questions? All right. So we can vote on these, how does the board want to move forward as far as?
Okay, I'm gonna make one simple motion. I'm gonna motion to approve everyone except Reap coming back our next meeting with the language that you all get together and get hashed out, and so we can let Reap, and then we move forward, and everybody have a Merry Christmas and a Happy New Year.
Do I have a second?
I have a question of Mr. Wibbs.
Yes, sir.
First off, we haven't set a date for our next meeting, and it probably would be in January, I'm guessing. How would that impact you if we were to just delay this decision until then?
Under the terms that were proposed to us, nothing would count. We could not spend any money, would not incur any expense until after a contract has been reached. And so if you said, where is it, we will be in a hold pattern. I recognize that there's a problem with that for individuals. The sooner we get started, the more people that we can help. But, I mean, we won't be able to do anything at all until we do this. And like, we have not signed any lease agreements or anything at this point in time.
Okay. Would the first Monday of December be out of the question? It's the first of December.
My calendar's good for the 1st of December.
My calendar's good for the 1st of December. That's the 5th or the 1st? Monday the 1st?
Monday the 1st?
Yes, Monday the 1st.
We can clear the year and everything will be swell. Can you guys get together by then?
I'm sure we can.
Okay.
And then probably have the job descriptions also by
Everything.
then.
Thank you.
Okay. I will reluctantly go with Tommy. I just think that we tasked the staff to come with recommendations, and now we're kind of questioning their recommendations as to, I don't want to have to do all the legwork that they had to do, so.
Well, that's what we're here for, Chief. We're here to
I know,
kind of drill
I know.
down a little bit.
I don't
and,
think they would bring anything in front of us that they didn't think fit the criteria, so.
Well, sometimes, all questions aren't asked, and sometimes there's some obscurities that has to get cleared.
Have a good
so-
Thanksgiving, Tommy.
Okay, we have a
All right.
motion and a second. All in favor?
Aye.
Meeting, let me double check. I can't say that. Is there any other new business?
I just want to tell Tommy I still love him. so.
I
Okay.
love you too, Chief.
Our next meeting will be December the 1st in the middle of the Love Fest. Thank you. This
Thanks.
meeting is adjourned.